Welcome to Nurses Specialized in Wound, Ostomy, and Continence Canada's Continuing Education webinar in partnership with Accenture Technologies of Calgary, Alberta. I am Catherine Harley, the CEO of NSW OCC, and I'm excited to introduce the topic of this webinar, pressure mapping, an innovative approach to pressure injury prevention across the continuum of care. You can see from these objectives that you will be introduced to pressure mapping by a tissue viability nurse from the UK and will learn from her personal experience using pressure mapping in the community. You will also be introduced to a physician's research project to support clinical outcomes using pressure mapping to augment clinical assessment of the skin. In doing background research for this presentation, I was very interested to learn that pressure mapping is a continuous skin monitoring system that reveals persistent elevated pressure points at the precise location on a patient's body and analyzes the data. You get visual, easy to understand pressure images and the actionable information you need to ensure safe patient positioning. This reduces the risk of pressure injuries to improve care and safety. Before we get into the introductions, I wanted to clarify terminology that will be used in the presentations. On April the 13th, 2016, the National Pressure Ulcer Advisory Panel, NPUAP, now known as the National Pressure Injury Advisory Panel, announced a change in terminology from pressure ulcer to pressure injury. This actually makes a lot of sense as it describes injury to ulcerated and intact skin. Ulcer, by definition, implies open skin. While the term pressure injury is now used in North America, in this webinar, please note that you may hear the term pressure ulcer used for two reasons. First, Dr. Ho's research protocol was written while the term pressure ulcer was still being used, and so the language was continued throughout the research project. And secondly, in the United Kingdom, there has been no change to use the term pressure injury. The term pressure ulcer is still used because it was a term widely used already in the UK, and it's consistent with the European Pressure Ulcer Advisory Panel's definitions. And now, I would like to introduce our guest speakers. Our international guest presenter is Nicci Aylward-Wotton. She is a tissue viability nurse consultant with the Cornwall Partnership NHS Foundation Trust, Banham House, Bodmin Hospital, Bodmin, UK. Her area of expertise is in pressure injury reduction, and she has been involved in research projects to look at ways to reduce the pressure injuries in the frail elderly population and improve patient outcomes. Our second guest presenter is Dr. Chester Ho, MD. He also has a strong focus on pressure injury reduction. He is the professor and division director of physical medicine and rehabilitation and the spinal cord injury research chair at the University of Alberta. He's the Senior Medical Director of the AHS NRV Strategic Clinical Network in Edmonton, Alberta, and the University of Calgary W21C. Before we start with our two guest speakers, I would like to introduce Bruce Malkinson, who is the Chief Operating Officer of Accenture, to set the stage for pressure mapping technology in order to give you a frame of reference for the presentations. I will now turn things over to Bruce Malkinson.
Okay, thank you. I'm Bruce Malkinson, Chief Operating Officer at Accenture Technology in Calgary, Alberta. And our company is a leader in intelligent dynamic sensing. And we're pleased to be a part of the webinar today. And continuous monitoring, skin monitoring has been a key part of a key priority, of our company for many, many years, and particularly the fact that skin is a critical organ of the body, and that isn't continuously monitored. And without that kind of monitoring, pressure ulcers become a problem for those patients that are at risk, patients that are mobilized at home or in hospital beds or surgical tables, or even waiting for care. And those wounds become, of course, a serious problem, not only for those patients, but for family members, medical professionals, and for the facilities that have to accommodate that. Without continuous skin monitoring, managing those elevated pressures, clinicians don't have the information they need to intervene and prevent tissue breakdown that leads to pressure injuries. And so for the last 20 years, we've been developing technology and products to ensure that nurses and therapists have the information that they need to prevent pressure ulcers for those patients. Our continuous skin monitoring products are available for many of these settings, particularly for hospital beds in acute care. Our monitoring product is our Foresight PT system, and that system allows clinicians to monitor the pressure over the entire time that a patient's in a hospital bed and ensure that those persistent pressures are relieved when they do their regular turns, or to add turns, or to develop a particular turn strategy for an individual patient. And also to provide continuity of care between caregivers, or between potentially different parts of the continuum. So if a patient's been monitoring in a surgical procedure, that information can be passed along with that patient as they move into an acute care bed. In an operating room setting, the system can also be used. The sensors are used to measure those interface pressures on the operating table surface to ensure proper positioning and to monitor the patient during that procedure to see if any kind of changes occur pre-post anesthesia, or as the patient comes out of that following the procedure. And if those pressure exposures exist during the procedure, the patient can be repositioned when the opportunity exists, or from a continuity of care perspective, that information can be passed along with the patient as they move into an acute care bed. And with that, thank you for your time and for our opportunity to participate in the webinar.
Hello, thank you for inviting me to present today on continuous pressure monitoring and sharing the experiences that we've had in the UK. Today I'll be discussing the objectives set out on the slide. So just wanted to give a little bit of history of myself. I've been a tissue viability nurse since the year 2000 and been working on continuous pressure mapping since 2013. As you can see, had an array of presentations, and we've also had some awards which I'll go through in more detail. And we're currently working on a Health Foundation Scaling Up Award called Promise, which I'll discuss at the end of the presentation as well. So we started off in 2013 with an evaluation on continuous pressure mapping in the health community hospitals to see how the product worked and if it would be useful for us. We then started and have managed to have another bid from the Regional Innovation Fund for some £50,000, which we then decided we need to look into the community and see how continuous pressure monitoring would work for patients who didn't have people with them all the time. We then used that that study, which was a service improvement study, to go for the Innovation for Improvement Award, which was another £75,000, and that looked to improving pressure damage detection in the community. And Excensa made me a small bed map, a small chair map, which I was able to use for patients who were sitting out for long periods of time. We then had some further money and we were able to spread the learning from that, had another £30,000, and then that culminated in the project that we're undertaking now called Promise, which is pressure reduction through continuous pressure monitoring in the community setting. And as I say, I'll speak about that at the end of the presentation. So why did we feel that continuous pressure monitoring would be useful in the community setting? Well, first of all, there are 85%, it's estimated, of pressure ulcers develop in the community setting. This is an unpublished report currently by Professor Julian Guest. And by the age of 65, people will have one long-term condition. By the age of 72, people will have 2 or more long-term conditions. 10% of people aged over 65 live with frailty, and this figure rises between 25% and 50% for those aged over 85. So we have looked at frailty in terms of our screening, and one of the areas that we've taken a record of for the patients within the study. In 2016, the King's Fund report reported for Health and Social Care that this was an unmet need, and this was definitely something that we wanted to know whether continuous pressure monitoring could help those patients who had minimal support at home from caregivers. And then in 2019, the NHS plan discussed personal care planning and giving people choice and control, which we felt continuous pressure monitoring really supported that process. So what can pressure monitoring offer as a supplement to the clinical practice? So basically, when you're thinking about strategies to minimize pressure magnitude and duration, we need to be thinking about the posture of the person, the support surfaces they're on, and their level of mobility. With the patient in the middle of that assessment, continuous pressure monitoring and MDT working needs to support that process, which is what we found throughout our projects, and using that as part of your assessment, to help you with those options and those decision makings, and to review whether the care is what you would want it to be. So continuous pressure monitoring is the system that we use. We have a monitor that the patient and the carer can see, which is at their bedside, and then there is a map with 6,000 cells on the bed, which the patient lies on top of with a sheet in between. And then for the chair, we've moved to the SS monitor, which we can see on an iPad type monitor, which we can then demonstrate to the patient. And this is the type of image that a patient will see, particularly if they've got high levels of pressure. We've altered the sensitivity to enable the patient to see those pressure points easily. And during each of the projects, we've looked at the peak pressure index, which is a group of 9 pressure cells. We look at the content area and the gradient. And the gradient is very important when you're looking at the severity of the pressure ulcer. Also, when you're thinking about the posture, it's really important that you think about that symmetry and the position, i.e. whether the patient is laying down or sitting up. We also look at the centre of pressure. So when we're thinking about that pressure over time, has been lots of work done, most recent work by Case Omens in 2015, looking at how long particularly that tissue tolerance before they get a pressure ulcer, and the higher the pressure, the shorter the time, but it needs to be remembered that even with very low pressures, then there is that possibility that you will still get that pressure. And the reason why we use continuous pressure monitoring is because when we see patients in a chair, they sit like this, and that's when we might get a snapshot. But when we leave the house, it's possible that they will sit like this. And that's why by monitoring, we get a much better picture of what is going on. Or they might be sleeping like this, and we have no idea what the situation actually is in the patient's own homes. So this is just to demonstrate how important that pressure over time is. And as you can see, the beginning of the pressure monitoring, it appeared that the mattress was providing really good pressures. But after 12 hours, you can see that the foam is compressed and providing this picture with very high pressures in the sacral area. And because of this, we were able to discuss with the patient about changing to an alternative mattress and an alternative cushion, and she went on to heal. And again, when we're looking at this, I wanted to demonstrate to you, this patient had a chair map, which was only for a very short period of time. And if you look at the mapping at the bottom, then you can see that the peak pressure is the same, and that could lead you into thinking that everything is okay. And then when you look over the graph, you can see that over time, that pressure is increasing until we've gained 20 to 30 millimeters of pressure with a really high increasing gradient. And the tissue tolerance is then dependent on your skin elasticity, or how your muscles are, your vascular changes, and all those other things that we know that go on to influence that. So it will be different for everybody. So I've looked at the care continuum, and we've been working on that for the last 7 years. We haven't as yet taken the pressure monitor in Cornwall into the acute care, but we've looked at community hospitals, the patient's own home, and residential and nursing home care settings. So why the issue is such an issue in the community is that there's insufficient support for people with insufficient turning. We know that pressure reducing measures can conflict with people's normal lives. People might delay in seeking help or updating their equipment. Patients are often classed as non-concordant because they're trying to have that normal lifestyle, and often we don't know what's actually happening in a patient's own home. So in terms of where we are in Cornwall, you can see that we're right down in the toe of the UK. And these are the reasons that we started continuous pressure monitoring, and the incidents that we were getting. And we also have a very high incidence of elderly in Cornwall as well, compared to the rest of the UK. So the patient demographics are that the patients that we've looked at that are referred to tissue viability generally are in the older age group. The majority of the patients have been in their own home, with the majority being a frailty level of 7 and above. The patients with a lower frailty tend to be in wheelchairs, and we've had a predominantly female population. So what we've done is we've provided the patient with a seat sensor and a bed sensor onto the bed and the chair, and left it there for varying periods of time depending on the patient and the seat map, up to 72 hours in some cases, then fed that information back to the patient and agreed with the patient about the alteration in positioning, posture, and equipment and future management. So when we looked at the community hospitals, what we found was that although it was because it was a rehabilitation hospital and the MDT were working together, the patient was not on the bed for quite a long period of time. And you can see this grey bit here, and that's when the patient has gone to the physio or OT department. But what they haven't done is taken their cushion with them. So we were able to demonstrate to the community team, the community hospital team, that it was really important that they have 24-hour pressure management. We were also able to show that a patient at one point had been left on a bedpan for 55 minutes, creating pressures of over 56 millimeters of mercury, which was quite an eye-opener for the community hospital staff. And they then put in place a quality improvement initiative to make sure that that didn't happen again. As you can see, the community hospital project resulted in a reduction in pressure ulcers at that time. Unfortunately, we haven't been able to maintain that because we've had to remove the monitor, but that's something that we're looking at, is actually taking it back to the community hospitals on a more permanent basis. So within home care, this patient, I just wanted to demonstrate that they weren't able to use their hands and were using their bottom to slide out of the bed. And you can see that those pressures are really high. And by demonstrating that to the husband and getting OTs involved, we were able to look at different strategies to help the patient get out of bed. And this patient was not able to go to bed. You can see that they had developed very high levels of pressure. and we needed to have those discussions with OTs to do seatings assessments because he wasn't able to go upstairs. He was imminently going to be going to hospital or into a nursing home, but we managed to find a cushion that replaced that, so he was able to stay at home, and he healed without being admitted, which was really good, and still remaining in the chair for 24 hours. And this was another patient who was in the same situation and had Parkinson's and was having carers position her. And what I wanted to demonstrate here, that when healthcare professionals position over a 4-hour period, we can see that the pressures remain fairly steady and not too much of a problem. But again, the foam after several hours starts to compress, which increases the pressure. And then by having carers position, you can see that we have high levels of pressure as well. So we needed to have a cushion that would support the carers providing that positioning as opposed to healthcare workers. And we were able to do that. And this lady continued to sit out for 12 hours a day, and she healed within 5 weeks, which was incredible, really, considering it was a grade 3, category 3. We were able to reduce the district nursing time and also the tissue viability time. So within nursing home patients, I just wanted to demonstrate a patient who's in long-term care, had spina bifida, was sitting bolt upright all day and night with no backrest, a category 3 pressure ulcer, which they'd had for 18 months prior to continuous pressure monitoring. Several mattresses had been tried, but the nursing home weren't able to purchase or were reluctant to purchase. So what we were able to show is that by trialing several different mattresses, and you can see by the readings at the bottom that the final mattress we tried had quite a significant impact, and the patient went on to heal. And we were able to use this to demonstrate to the nursing home that they would, could they purchase the mattress that we had recommended in order for that person to heal and continue with. And he's still on that mattress and he remains healed, which is incredible. So these are just some of the things that patients have said with regards to using the monitor. And as you can see, the grandchildren have got involved and are able to see on the monitor the different colours and speak to Granny to say that it's okay, not to worry. And patients have also felt that this was amazing. It's given them control and stopped the guesswork. And this particular patient was able to attend hydrotherapy and is now able to sleep due to improved comfort. So I just wanted to go on to our current project, which is Promise, which is a quality improvement project scaling up with multiple partners. And you can see across the Southwest where we are at the moment. We had $500,000 from the Health Foundation, which helped us to scale up, and we're a little bit delayed in finishing, so we won't actually be finished until the beginning of next year. We've got 4 teams. One is a community team in Cornwall, because we want to see whether this is something that a generalist can take part in and lead, or whether the other 3 teams are tissue viability teams. We've also had an independent evaluator and been liaising and collaborating with Plymouth University and Southampton University. So we're looking at community pressure monitoring across the multiple community clinical sites, looking at what support is required to scale it up, evaluating the clinical impact of continuous pressure monitoring, identifying the differences in the translation to those different sites and how they potentially alter how it works, and then evaluate the economic and societal impact. We're using quantitative and qualitative analysis, looking at the demographics, medical history, medication, and pressure ulcer details, also the time it takes to find that solution. We're also looking at the qualitative analysis using pressure ulcer quality of life scores and equipment questionnaires, the wound size at the beginning and completion. We're collecting the peak pressure index, gradient, and surface area for both mattress and cushion, and monitoring looking at the length of time that they're actually being monitored. We're very lucky to have Professor Julian Guest on board, and he's looking at our health economics for PROMIS, looking at what equipment was used at the start and what was used at the end, and the cost implications of that, estimate of the healthcare resources use associated with PROMIS, looking at the total number of visits with regards to the MDT, healing rates, value-based outcomes. How would it have been different without PROMIS, prior to PROMIS, and looking at the assessment of whether PROMIS affords the NHS a cost-effective intervention and technology. So these are some of the feedback that we've had from patients so far with regards to using the equipment, and you can see that generally the feelings of the patients, which is close to 100 patients now in the PROMIS study, is very positive. And the reasons why we would suggest using continuous pressure monitoring is it gives biofeedback to both patients and clinicians. It promotes truly patient-centered care, increasing mutual understanding, improves patient choice and a return to a normal life. It provides a method of education to patients, carers and clinicians. It aids improvements in differential diagnosis by eliminating pressure ulcer as a source of the problem, if that is the case. It improves that MDT working, supports decision-making on future equipment purchases. It supports that clinical reasoning when requesting bespoke equipment choices, and enables procurement to understand why, with the evidence that you need different equipment. It provides a preventative tool, helps with hospital admissions, reducing bed days, and it's also aiding that patient discharge as well. With end-of-life care, it's helping us reduce pain and also is aiding the comfort of the patient in their final days, and also of the relatives who are much more reassured that their loved one is in a much better position and not in pain and sleeping better. So what we're developing as part of PROMIS is an implementation guide, a toolkit with assessment forms, referrals, how-to guides, policies and guidelines, also outcome measures that you should be looking at. We've developed patient and practitioner leaflets. We've also put together a business case to aid with the purchase of the technology in the future, educational videos on the setup and software use, a governance structure, which is really important, including risk assessments, how to get that IT support and the hard drives required to download the data, also frequently asked questions of the things we've learnt over the last 3 years. So in summary, posture, mobility, surface all need to be taken into account when preventing and treating pressure ulcers. Pressure over time is key to finding that solution. The multidisciplinary team working with the patient as an essential team member is paramount in ensuring the patient is at the centre of the decision-making process. Repositioning is not always possible in the community, and continuous pressure monitoring is part of the picture, helping to find the best outcome for the patient. With regards to clinical relevance, we know that we can achieve good clinical outcomes, and hopefully PROMIS will demonstrate that in the new year. We have evidence to show that we can reduce those equipment costs, visualise in real time the effects of pressure relieving equipment, helping carers feel more confident in identifying high pressure points. Continuous pressure monitoring enables pressure ulcer prevention to be truly patient-centred by fitting the equipment to the patient and not the patient to the equipment. I'd just like to finish by saying thank you to the nurses specialised in wound, ostomy and continence Canada and Accenture for asking me to present at this webinar. Also to SUMED for their support over the last 7 years, to the Regional Innovation Fund, Burdett Trust and Nursing Charity and Health Foundation for the funding over the last 7 years, and also to Professor Julian Guest and Dr. Peter Worsley for some of the slides that they've helped me put together. Thank you.
Thank you, Nicci, for the very interesting presentation. And now I'd like to tell you about the research that I do related to pressure mapping. The objective is to provide research to support clinical outcomes using pressure mapping to augment clinical assessment of the skin. And I have no financial interest in the technology or devices presented to you today. The title of my research is the effectiveness of a pressure sensing system to reduce the risk of pressure ulcer formation by lowering interface pressure in vulnerable patient populations. It's a parallel two-group randomized controlled trial. The funding of this research came from Alberta Innovates Health Solutions, collaborative research and innovation opportunities. And also, it is supported by W21C, or the Ward of the 21st Century, at the University of Calgary. Dr. William Garley is the overall PI for the AIHS project, and I am the lead for this particular research. I'm going to go through the background, the objectives of the study, the methodology, and also the current status of this study with you today. Basically, for our study, it is a parallel two-group randomized controlled trial that aims to study how the use of a pressure sensing device with continuous visual feedback of pressure mapping may potentially decrease the interface pressure of patients who are at risk of pressure ulcers in an acute hospital setting. And it is based on the technology from Exensor, which is a Calgary-based company that specializes in pressure sensing technology. Exensor collaborated with the Ward of the 21st Century in the design and pilot study of the Foresight PT patient turn system. But there is no financial relationship with Exensor in this study. So just to tell you something about the Foresight PT system, it continuously monitors interface pressure and provides continuous pressure imaging that quantifies real-time interface pressure information. It's essentially a mattress cover that contains as many as 6,000 built-in sensors. And also it displays a monitor that shows the interface pressure in real time on the color gradient image of the body. It also provides a patient turn tracking system to assist with the management of the patient turn schedule by alerting healthcare providers and or caregivers to the location of the body areas that have experienced the greatest exposure and when the next turn or repositioning is due as per the preset alerts. So if you want to set that as every 2 hours, you can do it that way. Or if you want to turn that as every 3 or 4 hours, you can do that too. Now, the next couple of slides will show you some diagrams of this system. So here you see on the right-hand side, we have the mattress cover basically wrapped around a mattress that you find typically in a hospital setting. It doesn't have to be a hospital bed, but this is what we use in our study. And then on the left-hand side, it shows a panel that the users can visualize the pressures on. So you see that there is actually an image of the body representing different pressures there by different colors. And then at the bottom, you see that there's the patient turn clock that notifies the caregiver that repositioning is due. And here, this is what the data may look like eventually. You see that on the right-hand side, we have the color gradient showing the different pressures. And so you see that red is the highest pressure, and then blue is the lowest pressure. And so by color coding the pressures, you see what type of pressure is actually present at what body parts. So in terms of the study, there are two objectives. The primary objective of the study is to test the effectiveness of this CPI system in its ability to reduce interface pressure as reflected in a composite of interface pressure analysis. Whereas the secondary objectives are more clinical. We want to assess whether CPI reduces the incidence of pressure-related skin issues. We want to determine the minimum interface pressure that's associated with higher risk for pressure ulcer development through the correlation of clinical outcomes and pressure outcomes. And also, we want to assess the healthcare provider and patient's perceptions of this system, because we know that is really important. So given the two objectives there, how are we going to do that? Our plan was to recruit 678 patients at the Foothills Hospital in Calgary, so that they'll be randomized into the intervention or control groups over a 3-year period. And you may know that the Foothills Hospital is one of the largest tertiary care hospitals in Canada. And basically, we target nursing units with patients at high risk of pressure ulcer development, such as on the medicine unit, neuro unit, and also the ICU. And we also want to make sure that the expected length of stay is at least 3 days, because we want to collect the data for a 3-day period. We also want to target populations that are less mobile. So we would like to see that they require assistance with bed mobility, or that they are completely dependent for bed mobility as determined by the bed components in the De Morton Mobility Index. So I talked about the randomization in the intervention versus control group. So how are they different? In the intervention group, basically, they get the standard care, and then the staff, as well as the patients and family, can see what is going on with the pressure mapping as displayed on the monitor. And then basically the staff and the caregivers can use visual feedback to make decisions on their care, whether a turn is due or whether repositioning is required. And at the same time, interface pressure is monitored continuously. As for the control group, they also get standard care. And while the pressure is monitored, but then they do not see that. So the staff or the family members or the patients do not see the pressure feedback on the monitor at all. So they cannot then get the visual feedback to make decisions as to whether the individual needs to be turned or repositioned. And so that is the control group. And in terms of the primary outcomes, we are specifically looking at the pressure analysis that include the proportion of participants that have pressure readings greater than 40 millimeters mercury. How did we get that number of 40, right? We actually got that number from our pilot study a few years ago, and we analyzed the data and found that to be an important parameter to use. And then we'll be also looking at the average interface pressure. And we'll also look at the absolute number of sensors with pressure readings greater than 40 millimeters mercury. As for the secondary outcomes, we'll be looking at, as I mentioned before, more clinical outcomes that reflect pressure-related skin and soft tissue changes, including skin discoloration, localized tenderness, without skin breakdown, and also any development of pressure ulcers. And we'll be looking at the unstageable and unclassified pressure ulcer development, and also suspected deep tissue injury, and any presence of skin or a wound infection. And then we'll also be looking at staff and patient acceptance and feedback. So where are we at with our study? Well, our recruitment has completed. It took us several years, but we made it. And so we have now recruited 678 patients from the Foothills Hospital, with 338 being in the intervention group and 340 being in the control group. However, we did have to exclude 171 patients because of some data issues. At this time, we are analyzing the data, and once we have completed that, we're hoping to write up the study to submit it to a peer-reviewed journal. And I'm very much looking forward to completing the manuscript, and hopefully we can share with you the results in future. However, I can share with you what lessons we have learned so far. What we have learned is that it is really important to see how we can incorporate pressure mapping technology into the daily workflow of the nursing unit. That was just critical, because if we do not incorporate the workflow into the unit, it would not be implemented properly. And also, it's not just good enough to look at nursing workflow, but also other workflow as well, such as housekeeping. I can tell you that actually at least one of our units was thrown away by housekeeping by mistake, because they saw that on the cover of the mattress, and they didn't realize that that was part of the study. So they actually put this into the trash. And so that was a big lesson for us to learn that in order to implement some technology like this, we really have to look at the workflow of everybody on the nursing unit. Now, we have found that there was really good staff and patient acceptance of this technology. And also, it was very interesting and perhaps not surprising to find that the recruitment in units where nursing staff are much more familiar with the use of new technologies, such as in the ICU setting, that was much easier. So that was what we learned from the study. And in terms of implementation of technology, I'm sure that that will be quite a similar experience as well. So these are the lessons that we have learned. And I hope to be able to share with you the data analysis in future. But I'm also hoping that with this study, you see that we can certainly incorporate something like pressure mapping as part of clinical care as well as a research program. Thank you for your attention.
Well, you can see that we have addressed all of the objectives that were set out for the presentations today in learning about this new innovation of pressure mapping. And I would like to thank our speakers, Nicci Aylward-Wotton, Dr. Chester Ho, and Bruce Malkinson, for really bringing mapping life. And now, if you look in the question and answer box on your Zoom platform, we encourage you to write questions that we will ask our keynote speakers to address. And we will now ask them to turn on their cameras, and we will move into the question and answer section. Thank you.